A very good afternoon to all. So, in lieu of time, we'll start this session. That's Trojan horse in glaucoma. Welcome, everybody. So, before we start the session, I would like to take this opportunity to thank AIOS Scientific Committee for giving us this opportunity. And for this session with us, the chairpersons who are joining us is Dr. Vinita Ramrani ma'am. All the chairpersons are requested to come and take the seat over the dais. Dr. Vinita ma'am, Dr. Manish Pandey sir, Dr. Dilip Lalwani sir, and Dr. Sahiban. To take you through this entire journey of Trojan horse, how it is there in glaucoma, myself, Dr. Shweta Tripathi, and my co-moderator, Dr. Vineet Ratra sir, we are going to sail you through this entire journey of Trojan horse in glaucoma. So for that, we are having a first dynamic and I can say a very knowledgeable person. That's Dr. Manish Pandey sir, who is going to give us a talk on managing a glaucoma suspect. Because we all know that glaucoma suspect, the main problem for glaucoma is the overdiagnosis and the overtreatment. So only if you know that how to go about a suspect, then only you can just prevent yourself from overtreating and overdiagnosis. Over to you, Manish sir. So I would request everybody who is there listening this whole talk, you can write down your questions. If it is not possible for us to take at the end of every talk, we can take it at the end. But for that, we need to be in time. So again, a request to the speakers, please stick to your allotted time.
Good afternoon. So we'll be talking about managing a glaucoma suspect and evidence-based algorithm. Thanks to all of you who are sitting here despite the lunchtime. So when you're talking about glaucoma and we are talking about suspects about glaucoma, we know that some of these suspects may convert into glaucoma, but all of them may not. Therefore, glaucoma suspects usually have certain risk factors, but no detectable glaucoma in them. But what are those certain risk factors that you're trying to look for? It may be a family history, it may be some imaging abnormality which has come up, it may be some abnormal angles. The optic disc looks to be a little suspicious. There is a high intraocular pressure and everything else appears to be normal, or probably there are some visual field defects or some other risk factors. But how do we decide? How do we take an informed decision whether the patient requires a treatment or does not require a treatment despite the presence of any risk factors? And what is that risk? The risk is about the risk of progression, that the patient is likely to progress if it is untreated. So, what are the options before a clinician? We will treat if the progression occurs, so therefore we wait till that time, or we treat if the risk of progression is high, that is only the risk is high, that is damage is likely with the current IOPs. The IOPs are very high and therefore if you leave it like this, it's likely to progress into glaucoma. Or the risk factors are so many that it overwhelmingly favors a treatment. The third option, do we treat all suspects? Anyhow, we are not doing this because that's the purpose of this talk that you are doing here. We need to balance the cost of therapy. The patient has to use a medicine to the quality of life. We don't want the patients to be using a medicine. The patient is always has a fear of going blind, and the physician desire is always of doing no harm. And there has to be a balance among these factors to decide whether we actually want to treat the patient or not. So we look at first factor, that is a primary angle closure suspect. Now, a primary angle closure suspect would basically mean the angles are opening on compression. There are no synechias, the intraocular pressures are normal, and there are no disc and field changes. Should we treat or should we not treat? The evidence to treat comes, it's indicated when the risk of a progressive disease outweighs the risks and side effects of treatment. When we talk about PSCS or narrow angles, the risk is conversion, and the conversion to primary angle closure or a primary angle closure glaucoma over a period of time. So what do we do in case we leave a primary angle closure suspect or narrow angles untreated? So one of these studies showed that 22% progressed to primary angle closure, that is the next stage, but none of them developed glaucoma and none of them had an acute attack. To treat or not to treat, for laser iridotomy for every subject is questionable. And because of the large affected population and low risk of progression, it remains a prophylactic procedure justified with a careful patient selection. We need to find out which sort of patient requires a treatment and which sort of patient does not require an iridotomy. Choice of situations may vary, but we have a family history, we have a fellow eye of an acute angle closure, you have some retinal issues which may require frequent dilatation of the eyes, or possibly when the patient is not ready for a follow-up, these are certain factors in which we can decide for a prophylactic laser iridotomy. Coming to the next one, that is an ocular hypertension. The pressures are high, but everything else appears to be normal. The optic disc appears to be normal, and your imaging modalities and the visual fields are also normal. How do you find whether we need to treat or not to treat? So OH2S actually randomized the patients to medication groups and observation groups and looked at the risk of conversion to POEG over a course of 5 years. And they did find that the risk of progression decreased from around 9.5%, that is the upper one, that is the observation, as compared to 4.4% in the treated ones. So there is a certain amount of risk which has come down if you treat these ocular hypertensives. But if you look closely into the picture, 90% in both the groups do not convert, whether we treat or we don't treat. So 90% of patients actually not benefited by either ways. They are not going to progress to an open angle glaucoma. So when should we decide whether we need to treat or not to treat? If you look closely in the picture on the left side in the upper one, you can see if the intraocular pressures are rising, they are high, and the central corneal thickness is low. That carries the highest risk of progression. And in case the risk of progression is very low, in case the central corneal thickness is on the higher side and the intraocular pressures are on the lower side. So there are 5 baseline factors which increase the risk of developing open angle glaucoma, which were older age, higher intraocular pressures, thinner central corneas, and larger vertical cup to disc ratios, and higher pattern standard deviations. Look at all these factors and look at the initial IOPs, the family history, the history of vein occlusion, disc hemorrhage, myopia, and increasing age, and then decide whether the person requires a treatment or not. Number 3 is a suspicious looking optic disc, but there are no visual field defects. Rule out other factors such as physiological cupping or anomalous looking optic discs. Have a baseline documentation including disc photographs that I feel is very, very important for these sort of patients for a careful follow-up. A suspicious looking optic disc, some visual field defects, intraocular pressures of 22, no pachymetry done, and the patient was put on glucomol, jo ki chalta rahega. So that is not the kind of treatment that we need to anticipate. Look at all these factors in total and then decide whether a treatment is required. Don't base diagnosis and therapy based on a single test. Look at the disc, the visual fields, the OCT, the family history, age, IOP, and CCT, and look at the red disease and the green disease. A green disease basically means when you look at the picture on the right side, you will see some nerve fiber layer defects, but the visual fields appear to be normal, and there are no defects unless until there is a small dip, what we can see in the OCT. So everything appears to be normal. This is a green disease. Compared to this, a physiological cupping, visual fields are normal, but the OCT is showing defects. That's a red disease. But all glaucomas do not require a treatment. So this person had a trauma 10 years back and an angle recession. The IOP was 17 and 16, the CCT was 535, and despite the defects on the OCT, we have not treated and have asked for a routine monitoring because I don't expect this glaucoma to worsen over time. Look at the risk factors also finally. If there are no other abnormalities, look at disc photographs, have an annual checking, and look at other factors that need to be taken. Do no harm, see whether treatment will be of benefit to the patient, keep in mind the life expectancy and comorbidities, and that with a reasonable certainty, if you find that without the use of anticipated treatment, the patient will get worse, then only the treatment may be necessary. Thank you.
Thank you very much, sir, for a detailed, structured, I can say the outline that how we are going to manage a glaucoma suspect. So the discussant for this particular topic is Dr. Dilip, sir. Dr. Dilip, sir, what is your take from this particular glaucoma?
Fantastic talk, Manish. So a few questions. So you have a patient like you described in primary angle closure suspect. So what do you look for to treat? What do you look for to treat this patient to do a PI?
So all of these primary angle closure suspects will not require a therapy. I've told because of the large affected population and the low risk of progression. So if I find a patient who has a fellow eye which has developed probably an acute angle closure, or that has even a primary angle closure, that means the intraocular pressures are high, that has synechias in the eye, I would like to do a laser iridotomy for the fellow eye. If I find that the other eye or this eye has a history of vein occlusion, patient has a diabetic retinopathy, requires frequent dilatation of the eyes, I would like to do a laser iridotomy. If I find that there is a family history of angle closure, patient comes that they have somebody in the family, close family members, that may be siblings, maybe parents, has a history of glaucoma, especially for angle closure, they know that an iridotomy has been done, I'd like to do it. If I find a rural patient coming to me, a lot of rural patients come to me, and I find that this sort of patient is likely to be missed up, I like to do it. And finally, one small point which I have not put up there, if I find a very patchy pigmentation of the angle, that also is a relative indication that I take for doing a laser iridotomy in that sort of way.
And that's a very important point. If you see patchy pigmentation, you would want to treat. And otherwise, fantastic talk. So you don't want to over treat patients. You want to treat patients if there are risk factors, whether it's an angle closure, whether it's an open angle, uh, or any other patient. So like he said, do no harm. You first want to protect the patient, but you don't want to over treat.
So
Sir,
that
may I make a
with-
comment, ma'am?
yeah, sure.
Okay. So, so like you mentioned that the SN study gives a prevalence of conversion of PACS to PAC to be around 20 to 22%. The more recent trials, the ZAP trial and the Singapore trial, which was also headed by Bhaskaran sir, actually shows even lower rates, like in 6 years 4% progression, and in the Singapore trial 1.6% progression in 5 years. So now, owing to such low rates, yes, I totally agree that LPI should be done only in very high risk cases. Another symptom I think we may watch out for is intermittent headaches, intermittent blurring of vision, redness. When patients complain of these, they're probably experiencing intermittent attacks of angle closure, and those symptoms also that bring them to the hospital should not be missed, and maybe provocative tests or biometry like ASOCT can be performed, because that is also a very important tool to risk strategize the patients for LPI.
Thank you very much. So, in lieu of time, we'll move further ahead. And before we go into the second speaker, let's invite and welcome our very important keynote address, which is going to be addressed by Dr. Saurabh Goyal, who is among us and who has spared his valuable time all the way from UK to come and spare his time to speak on this topic. So, just a brief introduction about Dr. Saurabh Goyal. He is a DNB MS from Surat and MBBS from Indore. He is right now presently working as a consultant eye surgeon at St. Thomas Hospital, London, and he has done his fellowship in glaucoma from St. Thomas and King's in 2006, fellowship in cornea from St. George's and Moorfields, fellowship in glaucoma from Moolsfield Eye Hospital, and he is working as an honorary lecturer at King George's College, London as well. He's been a principal investigator for different RCTs like Eagle, PTVT, TAGS, Peace, and Concept. We are glad that Dr. Saurabh has spared his time to spend with us, and he's going to give us a keynote address on pearls and pitfalls in management of advanced glaucoma. So going from suspect straight away going to the advanced glaucoma. So let's hear him out.
Thank you, Shweta, for the introduction, and thank you for the invite. Thank you, Amit, Partha. So I'm just going to cover what's the definition, a few diagnostic pearls, what's the aim of the treatment, what are the surgeries which are effective in this, any role of MIGS or maximally invasive surgeries. And I'll touch on the advanced angle closure management as well, risk of wipeout and possibly neuroprotection in the future. So we understand that this minus 12 decibel field loss is what we define as advanced glaucoma by HODUP classification. But what we don't talk about is any central point, 0 decibel, is also advanced glaucoma by definition. Or whatever may be the mean deviation, but if one point is 0 decibel, then that's advanced glaucoma. Also, any 2 points in 2 hemifields which are less than 15 decibel, that's also advanced glaucoma. So these patients are also at risk of losing central vision. That's why it is classified as advanced glaucoma. But when we talk about very advanced glaucoma, these are the patients which I have treated in the last few years. Most of them are one-eyed patients. They have 25 to 30 decibel field loss. And US government defines blindness as 22 decibel field loss on Humphrey fields. So let me talk to you about this case. 70-year-old barrister who has been having glaucoma for 5 to 6 years and now been referred to me for surgery as his one eye is getting worse. He's in maximum medication, 2 SLTs, thick corneas, pressures are uncontrolled, and he's got significant coupling. So these are his fields between 2019 and 23. So when these patients come to me, I don't just believe on any finding which comes to me. I look at the patient again, history, full history taking, including migraine, Raynaud's, and their examination including color vision, gonioscopy, disc assessment, gonioscopy being the most important. So in this patient, as you can see, the vision is 618, but the color vision is very much down to 0/17. Now that's a red flag. In glaucoma, you shouldn't lose central, unless you have lost central vision fully, you don't lose the color vision. So I booked him for surgery for the 1 week, but I said, look, I'd rather do a MRI as well, just to make sure. And he had a meningioma. So just by doing that color vision test, you can pick up pathology which is non-glaucomatous. So the take-home message is, if there is advanced glaucoma, it could be even tunnel vision. But if the central vision is preserved, then you shouldn't lose your color vision. And you have to think about non-glaucomatous optic neuropathy in these patients. What about these type of patients who have nearly end-stage glaucoma? One eye is PL, the other eye is hand movements, and this patient wants to retain this hand movements vision. When you check his pressures on Goldman is 60, on eye care is 6. So what pressure do you believe, which is the correct pressure? So I often use my fingers to judge these patients by using digital tonometry to see what the pressure feels like. And I ask the patient, he tells me if he's getting worse, if he feels the headaches, he tells me. And to monitor progression in these patients, not particularly like so advanced, but you can use central vision, subjective level of vision, I find very useful in these patients. They tell you if they're getting worse. Confrontation visual fields, central 10-2 of definitely as compared to 24-2. But the key point here is that OCT has no role in management of progression in these advanced glaucoma because of the floor effect. So what you see is an early stage pre-perimetric OCT is very useful, but towards the end, you have to rely on visual fields or possibly ganglion cell thickness on OCT, but not the RNFL thickness because of the floor effect. So you see this 60-year-old chap who has got nearly end-stage glaucoma, his OCT RNFL thickness is 61. And this is a young patient with 62 with a nearly normal field. So you can't rely on OCT, and there is no classification on OCT to define disease as mild, moderate, or severe. So even if somebody is blind, the OCT thickness RNFL will not be less than 40 because of the floor effect, because of the glial cells, scar tissue, etc. So coming back to this patient, is it worth treating? So he clearly says, look, I would like to retain this hand movements. When somebody comes close to me, I know who is there. I can see the shadows. I can see where the light is. And so I have been treating him with cyclodiode laser every 3 to 4 years when he feels that the pressure is going up, when my fingers feel the pressure is going up, and he's still able to see hand movements vision. So what I have learned from one patient as a SHO is that he asked me, he was NPL in one eye, PL in the other eye, and he said to me, doctor, will I go blind? Now I'm thinking, by all definitions, you are blind many times. But for him, that PL light is also very important. So for me, I wouldn't give up unless the patient gives up on that level of vision. So any level of vision is worth preserving, especially in one-eyed patients. Also, I would like to say, don't give up on amblyopic eyes. Sometimes you say, oh, this eye has amblyopia, don't treat it or don't need surgery. But actually, I've seen patients who then lose their good eye for whatever reason, whether it's trauma or due to advanced glaucoma. Their amblyopic eyes can pick up vision to up to 6/9 level I've seen as well, who were 660 before. So don't give up on these eyes as well. This is a difficult case, 40-year-old lawyer who has aphakic glaucoma, only eye, other eye is blind. Pressure is 38, she's 38 weeks pregnant. She's had 2 trabeculectomies, needling, cyclodiode, micropulse, and she's been progressing. And at that point, she was referred to me and sitting in the chair, and I said, look, if I don't do surgery for you next week, you won't see your child in another week's time. And that's the kind of decisions you have to make with these patients, and you have to choose the right surgery in the first instance. So for aphakic glaucoma, a trabeculectomy is not necessarily the best surgery. So she had an Ahmed valve, and now she's 6 years down the line, pressure of 12 just on 1 drop, and 6/9 vision. I would like to give tribute to Mr. Mateen Ahmed, who is from Bhopal and who moved to California, and he produced this valve, which is used in India as well very often, about, I think, 300 to 400 every month, as I understand. So in your glaucoma clinics, in general clinics, the key thing is refer your patients early, the ones who are progressing. Don't hold on to them, because the first surgery is the best surgery. Don't poison the conjunctiva with too many drops, and avoid red eye causing drops. If you look at just the 9 drops, which are the commonly used drops, not even the combination, not even the Roaccutane and other inhibitors, recent ones, you have at least 255 combination of drops that are possible. You can spend all your lifetime just changing the drops. So you have to use your glaucoma bar very, very judiciously. For me personally, a prostaglandin at night, a combination of beta blocker and a carbonic anhydrase in the morning and evening is the maximum treatment. And then I proceed to surgery or even start talking about surgery. And these are our nice guidelines as well. I try and avoid alpha-GAN. I try to avoid bimetoprost because of the scarring and the red eye causing tendencies. So if you mix your drinks, you won't be healthy. You'll feel sick. Similarly, the eye feels sick when you mix all the drops. And if you do a surgery in a patient like this, that's not going to work because the eye is so red, it's so inflamed, it's going to bleed. So you have to avoid causing red eye in the first place. As regards the target pressure, we know less than 14 is good. We've seen this from ages. But in very severe glaucomas, you are aiming for 4 to 8 millimeters of mercury of pressure. And drops don't achieve that, lasers don't achieve that, MIGs don't achieve that. We did a review of mixed devices, and there is a floor effect of 15 in these devices when you combine with the cataract surgery. So again, not useful for advanced glaucomas. We know from 30 years surgery is better. And trabeculectomy for me is still the gold standard, a tube for very complex cases, or a combined tube and trab in those with very high risk of trabeculectomy failure. There is no shortcuts. You have to talk to the patients, and there are other measures you take, like we have an eye clinic liaison officer who talks to the patients about counseling and support to these patients as well. So I was part of this trial, and we learned from this that both work well, but trabeculectomy achieves slightly lower pressure with less medications, with less failure rate. In NTG particularly, you have to do a trabeculectomy if they are progressive. That's my understanding over the years. Pressures presenting with 18, 19, now 12 on drops, repeated, very advancing fields, disc hemorrhages. And this is patient after 10 years, 4 and 5 pressures. And look at her field. So this is actually recent one, and that's the starting one. It's not changed at all. In fact, slightly better over the years. And similarly in the other eyes, improved over the years. And fields can actually improve when you achieve such low target pressure. This is another patient with central defects, and after just 2 years, the central fields have become better because the pressures are much lower now. I was part of this STAG study which showed that the trabeculectomy achieves lower pressure than medical management, and NICE guidelines recommend to us to do surgery in these patients as well. But when somebody has got high risk of failure, like this Afro-Caribbean who has tendency for keloid, then I tend to do a combined surgery, mitomycin high dose, Barwell 350, and we call this maximally invasive, you can call it if you like. And this tube is completely tied with a nylon and a supramid suture so that there is no flow. Trabeculectomy gives us control for the first 3 to 6 months, and then the tube matures, and then ligating sutures, and then the ripcord sutures can be taken out. And she's done well, and now we have a series of about 40 cases over the last 8 years. Most of them have got 3 years follow-up, pressures of 11 in these patients. This is another technique which I described a few years ago in advanced angle closure, where if you have more than 270-degree synovial closure, then I do a phaco, IOL, ECP laser, endoscopic cyclophotocoagulation, and endosynovial lysis by using a spatula to open up these angles. So this has been found to be, again, quite useful for us, and we now have over 15 patients. Other things we can do is nicotinamide, which is the new drug which is being trialed, which is vitamin B3. And in advanced cases, I give it to the patients building up to 1.5 grams because there's a lot of animal evidence, early evidence to suggest it's a neuroprotective agent. Risk of wipeout, please don't worry about this. It's very rare. Don't hold your surgery. If somebody has 3 quadrants affected and you're doing cataract, you have to monitor it very well afterwards to make sure the pressure is not rising the same day, the next day. So in summary, I would say color vision is important in glaucoma and non-glaucomatous difference. Don't give up on any level of vision. Prevent advanced glaucoma by treating them properly. Refer early. Don't poison the conjunctiva. Surgery is the best chance to reduce the pressure at ultra low levels. Trabeculectomy is the gold standard. And consider vitamin B3, especially once we know from the trials. Consider tubes in secondary and complex cases. Thank you very much.
Thank you, Dr. Saurabh, for beautifully highlighting out the important points to be considered while managing advanced glaucoma. So I would request the next speaker, Dr. Reena Sharma, until her presentation is set up. We'll just have 1 or 2 questions. So the two points which I would like to share with everybody, taken from this particular talk itself, is that whenever you are diagnosing a case of advanced disease, never go with the OCT, because of the floor effect, it will not give you a correct outline that where your patient is actually standing. Second is that whenever you are planning to do a surgery, that too with a high pressure and advanced glaucoma, please go with a gradual decompression, but don't be scared of wipeout phenomena. Wipeout phenomena are rare, but yes, they are reversible also. But for that, meticulously closure of the wound, that is a tight sealed wound, is actually required with a gradual decompression. And anything more to add, sir? Vineet, sir?
Fantastic talk, given good points as to how we should handle. How many of these do you treat all your advanced glaucomas with mannitol before you take them up for surgery?
So after I left India, I've never used mannitol in 22 years. It's something which is not, it needs monitoring for elderly patients, so we don't do mannitol at all. Just as somebody said, slow decompression, pre-place releasable sutures, that's usually enough for these patients. Or you can put AC maintainer for high-risk cases. So especially young patients, high myopes, you put AC maintainer to maintain the pressure during the surgery so it doesn't collapse quickly.
So do you give them acetazolamide?
No, not at all.
Nothing. So you just take them up. Do you give them steroids prior to?
Yes, so that definitely we do. So I would, like the last session also said, so certainly if they are on red eye causing drops, we'll stop them, FML for a few weeks and Diamox if required. But for advanced glaucoma, because in the Afro-Caribbeans, I'm doing combined surgery because the traps heal after 6 months or 1 year. So the tube is already there and the tube is closed completely. So you can open up whenever you want by lasering the suture nylon and then taking out the ripcord suture.
Thank you.
Dr. Saurabh,
Nice talk, sir.
I have one question.
Just wanted to ask one question.
Yeah.
Like if the advanced one-eyed glaucoma patient has cataract, so would you prefer to do combined cataract glaucoma treatment together or one by one?
Yeah, so this is a very useful and important question. So it all depends on the pressure. If the pressure is uncontrolled, I would do a drainage surgery first and then them to understand that we will need to take out the cataract afterwards. If the pressure is reasonably well controlled, my approach is to do a phaco ECP first, so that gives us some control along with the ECP, and then do a drainage procedure afterwards. Because once you do trabeculectomy, the cataract will be there, and then you will have the failure of trabeculectomy. So my approach is to take out the lens much earlier on these patients, and then do the drainage procedure if the pressure is controlled.
Does that increases the risk of wipeout because we are subjecting a one-eyed patient with very advanced glaucoma to the two surgeries?
Correct. So that's the thing I was trying to say, that if you control the pressure immediate post-op period very well, so on the same day, so I often do their surgery in the morning, see them again in the afternoon, see them next morning, because these are the pressure fluctuations which causes the wipeout. So if you monitor them well, if you treat them well, then I have only seen one patient in 17 years, which was a patient done by angle closure eye, cataract, and then not seen for 2 weeks in a colleague's farm because they were not glaucoma trained. So, and the patient comes with a counter fingers and a hand movements vision afterwards. So that's very rare. I have not seen in my practice wipeout at all.
And how do you test the IUP? It's by applanation after 6 hours?
Yes, applanation, yeah. Okay. Or eye care, whichever is
Thank
available.
you.
Thank you very much. With that, we move ahead to Dr. Reena, and I would request all the discussant to please note down your questions so that we can take it at the end of the session. So, Dr. Reena, up to you.
Okay, thank you, ma'am. Good afternoon, everyone. So today I would be speaking on the topic pragmatic approach with the newer drugs in glaucoma. So we all know that as far as anti-glaucoma drugs are concerned, we have come a long way since the first introduction of pilocarpine in the year 1877. Since then, multiple drugs have been introduced, but we are still to get the ideal anti-glaucoma drug that we want. And for last nearly 2 to 2.5 decades, we have been considering prostaglandin analogs to be the first drug of choice. Now, why do we need these new drugs? Is because majority, in fact, all of the anti-glaucoma drugs that we are using have multiple systemic as well as local side effects. Plus, we also have some gray areas that we have not worked upon till now. That includes the neuroprotective effect that is needed. We need more drugs to act on the trabecular meshwork that is actually the primary site of problem. We need preservative-free drugs to prevent the ocular surface problems. Patient with difficult conditions like asthma and heart disease and allergy, uveitis, there we do not have many options, so we need newer drugs. Multiple drugs with novel mechanism of action, new formulations, and new drug delivery mechanisms are currently in development, but the newer options that have become available include the Rho kinase inhibitors, which have become a widespread usage, include natarcidil and ripasudil, and the promising drugs that are not yet available in India include natarcidil latanoprost combination and latanoprostene bunod. So a little about these. ROCK inhibitors basically act to inhibit the enzyme Rho kinase, which primarily is involved in extracellular matrix reorganization in the trabecular meshwork, and therefore Rho kinase inhibition, they primarily decrease the aqueous humor outflow, but in addition are also proven to provide some neuroprotective effect and also act as anti-scarring, which may be beneficial when we take up the patient for trabeculectomy surgery. Ripasudil was the first anti-ROCK inhibitor that was introduced, and it is used in a percentage of 0.4% in BD dosage. It decreases IOP within 2 hours of installation and has been proven to do consistently over a period of full 1 year. And what is important to know is that it lowers the IOP not only in the higher ranges, that is above 21 mmHg, but also in the lower normal and in the borderline cases. So that is where it may be beneficial in early open angle glaucoma patients and also in glaucoma suspects. In addition to ocular hypertension and open angle glaucoma, the drug has also been found to be very beneficial in patients with normal tension glaucoma, even angle closure glaucoma, and steroid induced glaucoma. So, the side effects, as far as ripasudil is concerned, the majority of the side effects occur locally. The systemic side effects are very rare. Conjunctival hyperemia was found to be the most common side effect, affecting almost 65.3% of the patients, though it was found to be often mild and transient. However, the post-marketing studies that have been done assessing the side effects of ripasudil, it has been found that the conjunctival hyperemia is found even in a lower percentage of patients, affecting only around 4% of the patients who use the drug. Natarcidil is the next ROCK inhibitor that became available. The advantage with this drug is that apart from being a ROCK inhibitor, it also lowers the episcleral venous pressure and also decreases the aqueous outflow production by causing norepinephrine transporter inhibition in the ciliary body. So, given the multiple mechanisms, the drug may be or is considered to be more efficacious. The active metabolite is natarcidil AM, which decreases IOP within 2 hours. A peak is there at 8 hours, and the effect lasts for at least 24 hours after the dosing. So it's used in a percentage of 0.02% as once daily, thereby taking care of the patient's compliance. Phase 3 Rocket 4 studies have found natarcidil OD to be non-inferior to timolol BD, and this efficacy has been found to be there consistently over a period of 1 year. Majority of the side effects here also are transient and they are ocular only. Systemic side effects are less common. Conjunctival hyperemia, corneal verticillata, and conjunctival hemorrhage have been found to be the most common ones, though the verticillata has not been found to affect vision and the changes have been found to be reversible. If we talk about secondary glaucomas, we do not have a conclusive evidence in terms of the clinical studies that have shown these drugs, that is ROCK inhibitors, to be efficacious in them. If we consider the other uses of ROCK inhibitors, they have found good outcomes in using the drugs in corneal endothelial diseases, and there are other areas where the drug is still being studied. Then the other combination that is available, that may be available soon, is netaserdyl latanoprost combination, which was FDA approved in March 2019 for use in primary open angle glaucoma and ocular hypertension. The advantage here is that there is a supraadditive effect of the two drugs, and it has been found that almost 40%, that is 30.9% patients achieved an IOP reduction of more than 40% from the baseline. And it was also the conjunctival hyperemia was the most common side effect. Then we have latanoprostene bunod with the dual mechanism of action, which also appears very promising in terms of control of intraocular pressure. Now, why should we use these drugs is because these drugs have a distinct mechanism of action, and they are mostly used in a OD or BID dosage that takes care of the that may take care of the compliance of the patient. And they also therefore help in like simplifying the regimen in patients who are using multiple medication. Very good in patients with cardiovascular disease, and would be good in patients where we are finding the patients to be they're finding it difficult to use the prostaglandin analogs. Also in patients with uveitis or where the prostaglandin analogs are not effective. So thank you so much for the time.
Thank you, Dr. Reena, and I would request Manish sir to just share some clinical pearls with the audience. In the meantime, I'll request Dr. Neelam Verma to come and just see her slides.
Thank you, Dr. Reena. Now, when we look at these newer drugs, there is always some sort of fantasy involved that they are going to change some things. For me, they are more as an adjunct. I'd like Dr. Saurabh to just give me some idea of whether they are treating these drugs as a primary therapy or as an adjunct to whatever we are trying to use. The second part of the question would be the combination of latanoprost and netaserdyl. Since both of them are used once in a day, is it available at your place, and whether you think that is going to substantially change management strategies?
We don't have these drugs available in the UK. They have not been approved. Yeah.
And what about the adjunctive use or as a primary therapy in any situation, do you think? Any of these Rho kinase inhibitors?
So my view is, because I have seen some patients who come from India, they are on 6 drops, and only eye, advancing glaucoma. And I find even these cause red eyes, the netaserdyl Rho kinase inhibitors. So my concern will be mainly about side effects in the long term, and also surgery effect on the surgery. I don't know enough about these drops to guide you on these. Yeah.
So I think in a general consensus, I would say that we use it more as an adjunct.
Yes.
Both, is the panel agreeing on that?
Yes, yes. Always second or third line drug, probably third line. That's better. So with that, we move ahead to Dr. Neelam Verma. Dr. Neelam.
Yeah, good
And
afternoon.
I would request the second speaker to be ready since Dr. Bhalla is coming late. So after this, Dr. Vinita would be there.
Yeah, good afternoon, everyone. Thanks, AIOS and Dr. Shweta Tripathi for inviting me. So I'll be talking on glaucoma compliances. They are not moving, I think. The slides. Okay, as we all know that glaucoma is a chronic disease and it is mostly asymptomatic in the early stages. So it has a low adherence and a persistence rate, which could lead to its progression. So there are two terms which are related to compliance. One is the adherence and the other is the persistence. So adherence is a measure of degree to which patient will follow the instructions of his or her physician during a defined time period, whereas persistence is measure of time to first discontinuation. So when we talk of day-to-day basis, it is the adherence, and on long-term basis, we say that the patient is persistent. So I'll give you an example. If suppose a patient is prescribed pills twice daily for 30 days, the patient takes only 20 pills, so the adherence is 1/3. And if a patient is prescribed, say, drug X on January 1st, who fills the first 2 months of prescriptions regularly, but miss the one for March, is persistent only for first 2 months. So twice daily pills for 30 days. If patient takes once every alternate day, but continues to refill prescription every month, so the patient is persistent with adherence of only 25%. So there are some common obstacles to adherence in their decreasing frequency, like situational and environmental factors related to their medication regimen, patient related and physician related. So coming to one by one, So for situational and environmental factors, the common factors associated are denial, lack of education on the part of the patient, travel issues, cost of medication, lack of insurance. They might be single or staying alone. So we should be educating our patients more than studies have shown that patients who are educated by providing some written material or through internet or by family or their friends in just addition to their physician were better educated, and we should also be providing specific information about their disease and consequences and importance of follow-up. So related to medication, there could be complex schedules and side effects and tolerability. So one should be asking questions repeatedly to our patient about their drop taking behavior, and we can simplify the regimen to fewer daily doses. There might be difficulty administering patients because these patients, as we all know, are older patients, might be suffering from dementia, other diseases like rheumatoid, Parkinson's. So we can suggest some delivery aids. Forgetfulness, yes, is common. We can discuss strategies so that they remember putting their drops. We can associate with their some daily routine like brushing their teeth, or they can place at their bedside. Or cyclical behavior from white coat syndrome is like when patient becomes compliant just before his or her visit to the physician, maybe 5 to 7 days prior and after visiting. And the doctor's factor, we all know that we run busy clinics, so we should try to improve communication. We should teach we should not only prescribe medications, but teach how to instill medication, wait between two instillations, and also teach them the role of punctal occlusion and gentle lid closures, and finding adequate glaucoma treatment which fits best into the patient's lifestyle. And we advocate frequent follow-ups and testing if we think that patient is progressing despite compliance. So how do we monitor adherence? So there are some direct methods like observing the patient take the medication, but it is not feasible, and we can measure the concentration of drug or metabolite in blood or urine, but that is costly. And there are some indirect methods which are more commonly used like physician estimated, patient self-reporting, and questionnaires which are simple and more commonly used. Pharmacy refill rates. Then we can check the amount of medication in the bottle at each visit, electronic medication monitors, clinical response, and patient's maintenance diary are some other indirect methods. So what are the pearls for increasing the adherence in our patients? So we can spend some extra 2 minutes with our patients for educating them and communicating them better. Then we should try to improve our skills to best fit the medication in a particular patient and address if there are barriers present. So we should be have become non-judgmental so that patient can tell us about any barriers or inhibitions or factors associated with their non-compliance. Then we should be asking open-ended questions repeatedly and putting emphasis on their disease and how to decrease the progression, how to instill medication. So we should be talking to them at every visit and reinforcing them every visit based on patient's need, social circumstances, knowledge, and education level. Tracking patients who fail to follow up, maybe using a telephonic reminders for appointments, is another way by which we can try increasing the adherence of these patients. So the medications only work for patients who take them. Thank you with this.
Thank you, Dr. Neelam. I would request Dr. Vinita ma'am to give some clinical pearls for the same.
Dr. Neelam, nice presentation. The most important factor for glaucoma management and its progression is compliance and persistence, for which we should give a very good chair time. Individually, in my practice, I tell my patients to bring the medicines to me and I check. Most of the time, they might put prostaglandin analogs twice or thrice. So you have to check yourself about the bottles and the drugs which they are using. Secondly, it the treatment which you are prescribing to the patient needs to be individualized. You cannot prescribe medicines taking patient into the consideration. So always involve the patient in prescription, then only your glaucoma management will be successful.
Thank you very much. And
Thank
with
you.
that, we move ahead to Dr. Vinita Gupta. Dr. Vinita Gupta is from AIMS Rishikesh, and she's going to present to us beyond IOP, because we all know, and there's a preset idea in our mind, glaucoma is all about the numbers, but it's not about only the numbers. It's beyond that. Let's hear it out.
Sorry, the background is coming totally different. So I think the
So
slides
should we call the next speaker till they are setting up your slides?
yeah, I think go for the next.
Just
There could be little difference.
no, it's all
No, no, the
distorted.
background is totally changed.
Yeah, it's distorted.
Okay, so in the meanwhile, can we have Vineet sir? Vineet sir, are you ready? So can we go ahead?
So one point about the previous talk, it's a good point to actually tell patients, give them like your habit with lunch, dinner, when you're giving your breakfast, when you're having your drops. Everybody has a mobile phone. So I tell them set alarms permanently. You have apps also to remind you to take
Like very
medicines
very
regularly.
correctly said by Vineet sir, I tell my patients to, even with clubbing with your daily activities like brushing your teeth or whatever, morning, breakfast, lunch, whatever, when you're starting for your office. So just club it with your daily activities. And that way, so now since the slides are being set up for Dr. Vinita, in the meanwhile, Dr. Vineet Ratra sir is going to tell us some clinical tips as it's beyond trabeculectomy. That's once you have done the surgery. Now we say that glaucoma surgeries are one of the most unpredictable surgeries. The surgeon itself doesn't know that how the bleb is going to behave. So let us see that how the bleb can give you certain challenges and what are the points which you need to keep in mind while tackling these challenges. In the meanwhile, we can have some questions from the audience, if any. You can even ask beyond the topics also. The forum is totally open to answer any questions with the stalwarts having with us on the dais.
Shweta, can I ask one question?
Yeah, sure.
Dr. Saurabh, so what is the maximum pre-op IOP in spite of medications that you feel safe to operate upon a patient? Like patients with NVG on maximum medication, still their pressures don't come below 20. So they are like 35. So do you do a diode to buy some time?
Yeah, so NVG is a different topic. So NVG, my approach is anti-VEGF as soon as, along with some diode initially. Buy time to quieten the eye, no bleeding during the surgery, and then do a AMAT valve afterwards. That's typically,
And
if the conj is
PACG
very good, you
cases?
could do a trabeculectomy as well eventually.
And also angle closure patients, they somehow and then we if you use pilocarpine to bring down the additional reduction in IOP, then do you go ahead with diode in such patients also, angle closure
If
patients?
the acute attack cannot be broken, then you can do a very short diode like 8-10 burns that breaks the acute attack just by doing that, and then you have time to take out the lens afterwards. So that's my approach. If you can't break the acute attack, pressure is still 50, you do a diode 8-10 burns, and that breaks the acute attack, and then do a lens extraction eventually.
Okay, thank you.
So good afternoon. Good afternoon, everyone.
Yeah.
Good afternoon, everyone. I would like to thank AIOS and Shweta for having me here. So I make a very profound statement when I tell about trabeculectomy. It's a surgery I do because I have to do, not because I want to do. It's why, because you do end up with many bleb challenges. Well, what is trabeculectomy? Basically, you're just making a connection from the anterior chamber to the subtenon space, which causes an alternate pathway for the drainage of aqueous. So what does this finally lead to? It leads to, since there's an alternate pathway, you have another way where the aqueous can drain out. So it all depends on your conjunctiva, how the fibrosis occurs, because this determines the hydraulic conductivity and controls the fluid flow through the tissue. So if you have IOPs of around 10 to 14, it is associated with minimal fibrosis, and we know that it lowers visual field deterioration. So what is an ideal bleb? Well, you could have one which is functionally ideal, you could have one which is structurally ideal. So functionally ideal is one which lowers pressures to a target range. And what about morphologically? Is it really important? Well, there are many factors which are associated with it, but what would a perfect bleb be? One which is diffuse, has microcysts, is mildly elevated, and has a few blood vessels, though with a little paucity of vessels and moderately thick. So, well, is this a good bleb? Well, more or less, yes. You never know when, because these blebs do change over time. So, what happens to the aqueous which comes in these blebs? They go through the conjunctiva, they mix with the tear film and are absorbed by the vascular and perivascular conjunctival tissues. But well, you can have scarred blebs like this and still have normal pressures. How? How do you explain this? Well, this is because of the new incorporated aqueous veins, the normal aqueous veins, and the lymphatic vessels near the scarred margins of the surgical area, which help drain the aqueous and reduce the pressures. Well, there was this study in current opinion, this review article in Current Opinions, which looked at various parameters as to what would actually change the outlook of your trabeculectomy, and they found that others would, but type of a scleral flap, whether you made a square, rectangular, triangular, what the size of your stoma was, or whether you maintained the anterior chamber with air or saline or viscoelastics or what, didn't have any effect on the final outcome. So, following a bleb surgery, you do have various factors which include the pre-op risk factors, the bleeding intra-op, the release of different growth factors, all of which could finally affect the outcome of your bleb. We do use mitomycin more than anything else and a lot of steroids, sometimes non-steroidals, to help make our blebs look good and function well, both morphologically and functionally. So we do know this chart about what our early post-operative complications are. We do know that too low pressures are more challenging, and what our early complication of a shallow anterior chamber with a bleb leak is probably the one which we need to be most careful and prevent this from happening. So early bleb leaks, these occur because of either buttonholes, suture tracts, or leaks through the conjunctival edge. Very rarely do they lead to a shallow or a flat anterior chamber, but we do know that any leak in the early postoperative period can increase the risk of failure. So yes, so we need to prevent it. We need to make watertight closures while we are doing the surgery. We need to, because we do have sutures there, we need to tell the patients you should not wipe, should not specially wipe. If you feel there's something there, you just mop, put your tissue and come out, don't wipe it. If there are loose sutures or a suture tract, you need to remove it. And also see, sometimes using NSAIDs or atropine, you could have drug allergies. The conservative treatment, well, you could just patch the eye, use a bandage contact lens. You could use aqueous suppressants, antibiotic drops like gentamicin, which increases fibrosis. And there have also been reports of using oral doxycycline because of its anticollagenolitic properties to inhibit the matrix metalloproteinase. The other, if this doesn't work, then we'll need to take the patient in and do resurgery. So the second is an overfiltering large bleb. So in this sort of a large bleb, you can see there are a few corneal folds. The AC is moderate. Well, in this, you just need to increase the steroids. Very rarely do you need to intervene into these, more so when there is an iridocorneal touch, where you'll need to do a AC reformation with Helon and air. If there is an excessive leak through a scleral flap, then you'll need to resuture the flap. And if there are choroidal detachments with kissing choroidals, you'll need to drain these choroidals. The next is this, the ones where you're having corkscrew vessels, which is more a sign of that it's failure or a subconjunctival hemorrhage. When this is a flat bleb and a high IOP, so if there is a tight closure of the flap, you'll want to teach the patient to do a digital massage, release the suture or do a suturolysis. If there is a scarring of the episcleral surface, you'll want to give 5-FU injections, and you'll obviously want to do a gonio to see if there's any obstruction in the stoma, and if that is there, you'll need to remove it. For example, this patient, he was a young uveitic patient, and he had a subconjunctival bleed, but we did give him 5-FU, and this is his bleb at 3 months. The next is the encapsulated bleb. Well, this is seen in around 8.3 to nearly 30%. It's seen between 2 to 4 weeks after surgery. It is tense, elevated, smooth dome. So in these patients, basically what you have to do is just tide over the phase of around 2 to 4 months when it will spontaneously resolve. So you give glaucoma medications, reduce the intraocular pressure, allow the remodeling of the cyst wall, also teach the patient digital pressure and increase the steroid therapy. It's only when the intraocular pressure is not under control would you want to resort to either a bleb needling or a surgical revision. In late bleb leaks, well, the treatment is mainly surgical, where you'd want to do a conjunctival advancement and a transplant. In dysmorphic blebs like this, you will need to do an excision, though very rarely, if it's mild, you can give lubricant eye drops. Another dreaded infection, dreaded complication is a blebitis. Well, in this, there are various risk factors, and blebitis can lead to endophthalmitis and loss of eye. Well, to conclude, we need to look at future directions where we could modify the bleb architecture to decrease bleb complications. Well, obviously, a no surgery alternative is best, so probably newer drugs like netrosudil and triposudil or rokinase will work. We could think of other celioablative techniques which would work, and probably non-surgical techniques which will be dealt with soon.
Thank you, Vineet sir, for such a beautiful presentation and making everybody bleb friendly instead of getting scared of the leaking bleb or I can say overfiltering bleb. Definitely now we are much more aware that what we have to do in time. And just requesting Dr. Dilip sir to give a brief bottom line from this talk, the bleb challenges, since he's the discussant. And in the meanwhile, I will request, yeah, Dr. Vinita is there.
Thank you, Dr. Vineet. It's a good presentation. Nicely elaborated the blab failure and prevention of blab failure. And blab leakage is the most common problem, which should be controlled in otherwise. And first of all, blab, if failing, that you should take the leakage test and then it should be controlled otherwise. And I will have some query for Dr. Vineet, if I can ask.
Yeah, please.
If you are using mitomycin C, so what is the timeline you should remove that mitomycin C? So it's releasable suture in cases of mitomycin C, if pressure is otherwise controlled, like below 10.
If the pressures are controlled, I don't remove, I just trim the...
Trim inside the blab?
Yes, that's at the final checkup around 4 to 6 weeks.
4 to 6 weeks. Okay.
I think also, sir, to correct me if I'm wrong, at that point when you're judging whether to trim or to remove the releasable, and when I say this, I mean beyond 3 weeks, do you also do a digital massage and see that if the IOP is not coming down at all, then maybe pulling it off is also not a bad idea. If the IOP, however, drops down with aggressive digital massage, then maybe trim it. That's just a way to cross-verify whether what you're doing is right or not.
Yes, absolutely. So if you want lower pressures, so we were talking about 10 pressures and lower. So if the pressures are high, you would first want to do a digital massage, check how much the pressures are low, and then pull out the...
Even
do a gonio before that.
Yes, and
you want to always check whether your osteum is patent or not.
And even this could be a deciding factor for doing your ALS also. You do a digital massage, you see that your bleb is elevating. Then probably you can decide for your ALS also. That is after you have removed the releasable. Dr. Vineet.
Yeah, good afternoon, everyone. So I'll be talking about another topic which is like beyond IOP. Glaucoma division, as we know, has all evolved over the years. Now, what we say, the definition of POG is no more based solely on the presence of elevated IOP. An emerging question which has come up in our glaucoma management is the well-controlled patient actually well-controlled? So patients, various studies are there which have shown that patients progress despite a good IOP control as we are measuring in our clinics. So what are the various risk factors for this? We know the mechanical factors, IOPs and the IOP fluctuations are only one of them. It's a various vascular risk factors which are also coming into play, and they have an important role, which I'll be talking about. And these are basically the ocular perfusion related components, the autonomic dysregulation, which is because of various systemic vascular risk factors, the genetic background, and the disc hemorrhage, which I'll talk in my subsequent slides. So what is the role of ocular blood flow in glaucoma? This is what is one of the things which we have to look at beyond the IOP. Lower perfusion pressure has been strongly seen to be associated with increased prevalence of primary open glaucoma. And the sixth consensus publication in the World Glaucoma Association has now labeled the low ocular perfusion pressure to be an independent risk factor for glaucoma. And this ocular perfusion pressure is basically has to remain up at a certain minimal level to prevent any optic nerve perfusion injury. However, it goes low, then obviously there is a retinal ischemia, there is optic nerve ischemia, which as well as there is a reperfusion injury. And if you look at this equation, basically a low ocular perfusion pressure is associated with a low blood pressure and a high IOP. So these are the two interrelated factors which are responsible for deciding your ocular perfusion pressure. And in a normal eye, there is a normal autoregulation which is happening, but in patients of glaucoma, it has been seen that there's an impairment of your autoregulation leading to ischemic damage and finally the death of the retinal ganglion cells. So this altered blood flow in patients with glaucoma has been correlated with not only with the increased risk of having glaucoma, but also with a greater onset of a greater progression of your glaucomatous damage. And this has been seen in the OCT studies and by various ocular blood flow studies by using CDIs, where we have basically the blood velocities which have been seen to reduced in the patients of glaucoma, as well as the increase in the resistive index of these blood flow parameters in the short posterior ciliary, as well as the central retinal arteries and other retrobulbar arteries. And all these changes have been seen to occur before actual damage occurring to the optic nerve. So all these studies have documented that, which are from various populations all across the world, and they have shown that the reduced ocular perfusion pressure is an important risk factor for the development of glaucoma as well as for its progression. Besides this, the other systemic risk factors, the systemic vascular diseases, which have associated with abnormal ocular blood flow, are your systemic hypertension, diabetes, aging, migraine. It has been seen that 47% of the glaucoma patients suffer from systemic hypertension. So again, this has been identified as an independent risk factor for glaucoma. Again, almost 29% of the patients have diabetes, which has also been again identified as an important risk factor for lowering your ocular perfusion pressure. Aging also causes an increase in the resistive index of your retrobulbar vessels, again causing a reduction in the ocular blood flow. Almost 15% of patients also have migraine, which is, according to the collaborative normal tension glaucoma study, migraine has also emerged as an independent risk factor for visual field progressions and glaucoma progressions. Then we have around 49% of the patients who are suffering from obstructive sleep apnea. And how does this causes vascular dysregulation? Basically, it leads to hypoxia because of collapse of the airway occurring during sleep. And this also affects your blood flow and your retinal nerve head perfusion. Then about 25% of the patients of normal tension glaucoma have disc hemorrhages. Again, with disc hemorrhages, there is a defect in the filling of the blood vessels, causing, or there is a delayed filling, which again leads to vascular insufficiency of the optic nerve head, leading to a low ocular perfusion pressures. So there is a complex relationship between all these risk factors, which is actually causing damage to your optic nerve head by causing the loss and the death of the retinal ganglion cells. So the glaucoma damage, which is caused by this low perfusion pressure and ocular blood pressure flow, is been identified now as a very, very important cause, not only for the development of glaucoma, but also for the progression. So it is time to take this OBF seriously, because unlike the risk factors like age and CCT, which we cannot change, we can target this. And we can increase the ocular perfusion pressure. There are some medications which are known to do that, to increase the ocular perfusion pressure as well as increase the blood flow, and we should try more and more studies should be now targeted towards that. The second thing, as I've already talked in my definition of glaucoma, that neurodegeneration is an important aspect, which is the thing which is happening in patients with glaucoma. And this is a widespread degeneration occurring from the retina to the visual cortex. So lowering the IOP, so again, we have to look beyond IOP. So lowering the IOP is just not going to help and address this susceptibility of the retinal ganglion cells to degeneration. There are two types of damage which are occurring to the retinal ganglion cells. One is because of the apoptosis, and secondly is the damage to the RGC survival pathways. Both of them are occurring. So then comes the role of neuroprotection in glaucoma. And there are three strategies. One is to improve the optic nerve head perfusion. Second is rescuing these damaged retinal ganglion cells. And third is trying to regenerate this optic nerve. Certain medications which we have been using in our armamentarium of brimonidine has already been proven to have some neuroprotection, but the newer agents which have come up to increase the optic nerve perfusion are the ROCK inhibitors, centrally acting calcium channel inhibitors, and flunarizines. And then we have to rescue the damaged neurotrophins of the retinal ganglion cells, we have the neurotrophic growth factors, which can be exogenously applied or by enhancing the release of the endogenous expression of these factors, or we have one of this implant which is under trials in US, which is basically ciliary neurotrophic factor, which is implanted in the pars vena and stays there for life. And third is optic nerve regeneration. I'll skip this in the shortage of time. So beyond IOP is that next thing in the management of the glaucoma, which we are doing at present, is basically multiple considerations besides the IOP. IOP is only the starting point for us. Also remember, which I've already discussed, the patient has multiple other vascular diseases which have to be taken into account. Keep the treatment regime of the patient as simple as possible, which Dr. Neelam already talked about. Is compliance is very important, because the acceptability and adherence to the treatment, whatever treatment you're giving to the patient, is very important, because you have to manage not only his glaucoma, but you have to also give him a good quality of life. And his satisfaction will come only when he has happy with the type of regime which you are giving him, what is the quality of life which is giving him with all the whatever treatment you are giving to him. Recently, we are giving a lot of attention to the RGC index, which is basically based on OCT and SAP along with the IOP things to successfully determine what type of glaucoma is progressing or not. And then we have the role of the complementary and the alternative medicine.
Dr. Vinita, we are
the
just
last
running
slide.
short.
I'll just finish. Complementary and alternative medicine, which are basically the role of nutrition, role of antioxidants, yoga-based interventions, and finally, the meditations. A lot of work has been done by Dr. Tanuj Zada on this. And some role on estrogen is also coming up, especially for females in the postmenopausal age group. So in order to conclude, I will just say vascular risk factors are now important in the pathogenesis of open glaucomas and its related disease. Most of these glaucoma patients have related vascular systemic diseases. Therefore, lowering IOP is not just enough. You have to have strategies to improve the ocular blood flow. You have to have neuro enhancements, and future research for the complementary and the alternative medicine is very, very essential in this paradigm of the glaucoma continuum therapies. Thank you.
Thank you very much, Dr. Vinita. And I would like to call upon Dr. Bhalla. Dr. Bhalla is going to talk upon target IOP. That's, I think, the most demanded topic during when we are talking about the glaucoma discussion. So let's hear Dr. Bhalla.
Yeah. Thank you, everyone. Thank you, Dr. Shweta, for making me part of this very important session on glaucoma. I'm going to talk on target intraocular pressure. We are born with about 1 million ganglion cells in each eye, and about 5 to 10,000 ganglion cells are lost annually from aging alone. It is said that if human beings lived up to 150 years, almost every one of us would ultimately develop glaucoma. So we know what is the definition of glaucoma. These are chronic progressive optic neuropathies, and the single most important modifiable risk factor is management of intraocular pressure. What exactly is normal intraocular pressure? The so-called cutoff of IOP of 21 millimeter mercury is neither clinical nor evidence based of normal, but it's just a statistical construct. Hollows and Graham survey in UK found that mean applanation of IOP was 15.9 in male and 16.6 in females. So 2 standard deviation above the mean, which is 97 percentile, was calculated to be 21 millimeter mercury. And hence this figure of 21 millimeter mercury is considered a so-called normal intraocular pressure. So what exactly is target intraocular pressure? Various definitions have been given by various societies. European Glaucoma Society and American AAO has said that is estimate of the mean intraocular pressure obtained with treatment which stops further progression. World Glaucoma Association says it is the estimate of the mean intraocular pressure at which the risk of decreased vision related quality of life due to glaucoma exceeds the risk of the treatment. So target intraocular pressure is just a guesstimate range of intraocular pressure that is expected to at least slow the progression of the disease, if not completely halt it. And when chalking out the target intraocular pressure, we have to consider some parameters, and every patient needs to be individualized. So what are these parameters which need to be determined? One is thorough clinical examination of the optic nerve head, intraocular pressure, baseline intraocular pressure, 3 consecutive IOP measurements at different times of the day, and also follow-up intraocular pressure. Perimetry is, we have to take reliable baseline perimetry which demonstrates visual field defects, then central corneal thickness, presence or absence of pseudo exfoliation, and there are some also non-ocular parameters like age, patient's life expectancy, ocular perfusion, family history of glaucoma, because all these studies, CISTES, EMGT and AGES, have told us that older the age of the patient, more is the likelihood of developing and progression of the glaucoma. Optic nerve head evaluation is important because cupping normal disc can withstand pressure up to 30 millimeter of mercury well for years. But if there is cupping confined to one pole of the disc, it appears to withstand tension up mid to high teens. And if there is cupping at both ends of the disc, then intraocular pressure we have to target less than 15 millimeter of the mercury. CD ratio is another important factor while estimating the target intraocular pressure. We have to classify according to the CD ratio whether it is mild, moderate or severe accordingly. And there was a study done by Dr. Sihota et al. Where they found that baseline linear CD ratio on HRT to be a significant risk factor for progression at all stages of glaucomatous neuropathy in both POAG and PACG eyes. So perimetric staging is very important, and these are the ways to classify whether you have early defect, moderate defect and severe defect depending on the mean deviation and pattern standard deviation. I won't go into the details. So EMGT found that a greater mean deviation loss at baseline was a risk factor for greater progression, and CISTES reported that a unit increase in their baseline VF score was associated with 0.74 unit progression. So why have this concept of target intraocular pressure? Having ascertained the damage of visual field damage, baseline intraocular pressure and risk factor, an IOP that prevents further damage and progression, we have to set in our patients. But there needs to be a balance between setting an appropriate target and being over aggressive in IOP lowering to avoid side effects because of the drugs and also economic burden onto the patient. And what are the methods which are there to determine the target IOP? These are classified as either threshold or absolute cutoff value. Second is percentage reduction. Third is formula based. Absolute or threshold target range is easiest for clinician and is most often used. Percentage reduction and threshold IOP are used mainly in RCTs and studies, and so incorporation of patient specific data gives us a tailored result depending on this. So what is threshold intraocular pressure? This is target IOP used in this strategy is a fixed level of IOP 12 millimeter mercury depending on AGES findings. But despite AGES findings, this concept of threshold IOP is not evidence based, and participants in AGES were randomized to specific treatment protocols, not IOP targets. And it was also found that not all non-progressing patients had IOP of 12.3 millimeter of the mercury. So, and threshold or absolute cutoff value, it can be applied to a largest population, and AGES maintained that a target IOP of less than 18 millimeter mercury in moderate glaucoma showed no progression, and severe glaucoma rarely progressed if there was IOP of 10 to 12 millimeter of mercury. The percentage reduction has been incorporated in various studies like OSTS found that IOP reduction of 20% leads to progression in 90% of high risk eyes. EMGT1 IOP was lowered by 25%. In early glaucoma, only 72% progression occurred off treatment. CISTES aimed at IOP reduction of 38% and 46% in medically or surgically treated eyes. There are some formulas also for setting target intraocular pressure, but these are mostly not followed practically and clinically. So use of target IOP is widespread amongst ophthalmologists who treat glaucoma. And a multi-center assessment in France and Germany found that almost 70 to 90 95% ophthalmologists are using this concept of target intraocular pressure. Also, there are medical legal considerations given professional glaucoma societies guidelines from around the world which that recommend the use of target IOP. Failure to do so may confer medical legal liability in the event of glaucoma related claim. But there are also arguments against target IOP concept, because the AG's target IOP of less than 18 millimeter mercury concept is a wrong interpretation, and there is no Oxford level 1 or high quality evidence. So there are benefit versus risk. Concept is okay if the risk, side effects, cost are associated with the treatment to reach target IOP are not significant. But I'll just take 1 minute more, sir. And target IOP can become an albatross for the practitioner who adheres to it when common sense indicates otherwise. I think it's stuck. These are the potential limitations of target intraocular pressure. Then there is a concept of dynamic target intraocular pressure and not static target intraocular pressure. These are the consensus expert recommendations by CGIG, AAO, and European glaucoma guidelines. So the WGA consensus statement says, promotes the use of target IOP determination in the management of glaucoma, but acknowledges limitation. There is lack of validation. So target IOP is a guess. Target IOP principle recognizes that lower IOP equals better IOP, which is not always the case. And this is in POAG and PCG with moderate glaucomatous damage, target IOP of 12 to 15 millimeter mercury. In advanced POAG or PACG, aggressive approach, normotensive glaucoma, 30% reduction. In OHT or PAC with OHT, these are the target intraocular pressure. So this is the chart which has been prepared, that in ocular hypertension or PAC with ocular hypertension, target IOP set less than 18. Early damage POAG 15 to 17, moderate 12 to 15, and advanced low teens, that is 10 to 12 millimeter mercury, and normal tension glaucoma aim for 30% reduction from the baseline. These are recommendations in childhood glaucomas, which I'll not cover the secondary glaucoma because of paucity of time. So in conclusion, we know that IOP is the sole modifiable risk factor, and adequate control can prevent irreversible damage. So target intraocular pressure concept needs not only to be popularized, but also practiced for the patient welfare. Thank you everyone for your kind and patient help.
Thank you, Dr. Bhalla, for the wonderful talk and telling us that target IOP needs to be individualized to the patient. Thank you very much. Now, in the interest of time, we'll take the questions at the last, and I invite Dr. Shweta for a talk on cost-effective MIGS.
Thank you very much. At the outset, I would like to thank AIOS for giving me this opportunity. So straight away coming to my topic, that's cost-effective MIGS. This is the field which is evolving in glaucoma surgical field every day with new concepts. So let's have a look at why there are so many changes in the field of glaucoma surgery. So before that, let's have a look over the systemic review and meta-analysis, that what is the estimated burden with the blindness which is going to be induced by glaucoma. So by 2040, it has been said by Tham et al. That it on only Asia, there are 66.83 million people who are going to get, I can say, impacted by glaucoma. And that's a huge number. So only if we treat in time and we take the timely intervention, definitely we can prevent the burden on the society. And the core concept of glaucoma is basically all about lowering the pressure so that we slow down the disease progression. But at the same time, we should not forget that we have to preserve the quality of vision during a patient's lifetime. A faster ambulation, a healthy lifestyle, definitely which is warranted for our glaucoma patients. So when we go back in the history of glaucoma surgery in 1960s, when the world was evolving, when the first man landed on the moon, it was Keynes who came with the rescue for us in the field of glaucoma surgery with the evolution of trabeculectomy. As stated, and I can say endorsed by different studies, it said the trabeculectomy, that is intervening the trabecular meshwork, brings down the pressure. But that was not the end, though it is still the gold standard for surgery. But yes, when it comes to a faster visual rehabilitation and a faster visual recovery with the better results, there is an era which is coming up with the new beginnings, because it says that the concept of customization and early recovery is the core concept which is needed when it comes to the field, when we are talking about the customization of the cataract surgeries and giving a precise results. So it comes in the form of a minimally invasive glaucoma surgery, advantages. We all know that bleb independent procedures, the complications associated with bleb is definitely not there. And there, if the patient is not willing to go for an early transition to a major surgery and still not wanting to put the drugs, maybe you can just combine with the cataract surgery as well. Though the debate actually lies in the pipeline, that's expensive, yes, of course, and long-term results are awaited, but still it is a procedure of choice with different surgical options. So when we talk about the different types of glaucoma, let's start with the angle closures. Definitely this MIGS, that is the basic form of MIGS to start with, you can say the GSL. You can combine with the phacotrabeculectomy and get a good result. Like here, this was a case of 55-year-old individual who has, I can say, the beginning pressures of 32 with the advanced cupping, that is 0.8 cupping. So we posted him for this phacotrabeculectomy with IOL, but the patient wanted a sutureless surgery and that to a mix. So with due consent, we went ahead and we did the surgery. So after performing the full cataract surgery, so after performing the full cataract surgery, after implanting the IOL, we can see that after placing this Swan-Jacob lens, there was a cyclodialysis spatula which was entered into the AC. And with that, you can see with the tweak movement, that is what is a tweak movement. Tweak movement is that you move sideways and you dab the angle and you just release the synecdoche. And that's how you can see that there is a synecdoche release. The movement of the spatula and the release of the synecdoche. So in the end, with 2 years of follow-up, the patient is having pressures of 10 millimeters without any AGM to its addition. Now talking about the open angles. So now again, we talk about the cost-effective MIGS coming in the form of bent ebb internal needle goniectomy, where this is having again a promising result. So again here what we do is that after doing a cataract surgery, implanting the IOL, you put a viscoelastic over the cornea and placing the lens and see that how with the help of a simple 24 gauge needle, if you're not able to get the 25 gauge needle, with a simple 24 gauge needle, you bend the tip, you excise the trabecular meshwork, and that's all. The job is done. I can say a cost-effective version of KDB. And here, whatever the remnant was there of the TM, that was removed with the help of the forceps as well. So in end, I would just conclude my presentation saying that yes, there are many more matches which are being made with the combined cataract surgery and MIGS. It is our prerogative that what we want to choose, what works better in a hand, and of course, we should not forget the pocket of the patient. So definitely with that, I end the session. And the actual debate, we have already covered the points that the stage of the disease. This MIGS, please make sure that you are selecting the patients in a proper selection criteria. Don't start off with the advanced cases. Don't start off with the angle closure. Just go with the eyes which are having the TM, which is pigmented, along with the broad, I can say, angle structures, which are very much visible to you. In the initial phase, probably you can magnify and see the angle. That's all. And as AIOC says, that MIGS devices are just designed to address the treatment gap that exists between the medical therapy and more aggressive traditional surgical option. Thank you very much.
Yeah. Thank you, Shweta. That was a
Thank you, sir.
wonderful, nice talk, good illustration. We'll now have Dr. Swati talk about GAT decoded. Vinita, you'll want to say anything?
I would like to ask Dr. Saurabh, but is it going to replace trabeculectomy? Like, what is the percentage of MIGs nowadays you people do and the trabeculectomies?
So we have access to about 19 different operations now, except trabectome, everything else which is available in the world we have access to. But unfortunately, all of these don't achieve the low target pressure. The things which still work in my hands at least are trabeculectomy, tube, and cyclodiode phaco-ECP. So the MIGs come and go. We have trialed almost all MIGs. We have done dynamic studies on them, but usually TM surgeries, they scar up after 3-4 months, pressure goes up. So I would say one has to be very cautious, particularly in Indian context, about the industry is driven push towards MIGs. It's not really the solution. If somebody doesn't need surgery and you do a MIGs, that's fine. But somebody who needs surgery for controlling the pressure, MIGs are not effective.
So definitely, as very clearly said, that you have to choose your cases. You have to be very cautious while choosing your cases. The mild to moderate glaucomas, when a patient is on a single or a dual drug therapy, we never recommend it in going for the advanced cases. Thank you. So over to Swati. So again, one more cost-effective MIGS in the line.
Thank you, AIOC, for giving me this opportunity, and I'm not going to bore with my PPT, so I'll just have a video.
Gateway to Safe GAT, Gonioscopy Assisted Transluminal Trabeculotomy, or GAT, the brainchild of Dr. Devinder Grover and Dr. Ronald Feldman from Glaucoma Associates of Texas, Dallas, involves an ab interno canalization of Schlemm's canal to create 360 degrees of trabeculotomy. Conventionally done with an illuminated microcatheter, the low-cost option is by using 5-0-proline suture. Here are the must-have items for performing suture GAT. 5-0-proline suture, low-temperature cautery, direct Swan-Jacob gonio lens, high viscosity ophthalmic viscosurgical device, OVD, like Helon GV or Orogel, 25-gauge MVR blade, MST forceps, indirect gonio prism, McPherson's forceps. An ideal suture GAT surgery involves the blunting of the tip of the 5-0-proline suture using a low-temperature cautery to make small flange at the tip. Following this, the suture is introduced into the anterior chamber under OVD. A small 1 clock hour initial goniotomy is made in the trabecular meshwork using the 25-gauge MVR blade. Then, the flange suture tip is introduced into the Schlemm's canal using MST forceps under Swan-Jacob gonio lens visualization. With gentle strokes, the proline suture is advanced gently into the canal till it appears from the opposite side, where it is grasped at the tip above the initial suture and brought to the center of the anterior chamber. Finally, using a McPherson's forceps, the external suture is pulled out, creating a 360 degrees ab interno trabeculotomy. We share here some beginner's complications, and we will also focus on some tips and tricks to avoid them. Positioning and seeing the angle. Initially, during intraoperative gonioscopy, one will have air bubbles or too much pressure, which can result in indentation and failure to see the angle properly. But with practice, one can master this skill. A thorough preoperative slit lamp gonioscopy with special attention to the nasal angle is very important. Initial intraoperative gonioscopy can be practiced on routine cataract cases before initiating or after completing the case. Tilt the patient's head 30 to 35 degrees away from you and tilt the microscope 30 to 35 degrees towards you. Put a drop of OVD on top of the cornea and gently place the Swan-Jacob gonio lens over this drop. Adjust the microscope magnification. Start from a lower magnification and then slowly zoom up using the microscope foot switch. Routinely practice the foot switch of the operating microscope as both the hands get engaged while doing MIGS, so finer adjustments need to be done using the microscope foot switch. Ideal flange. The tip of the 5-0-proline is blunted to form a small flange using low temperature cautery. This is to make the tip atraumatic and facilitate its smooth passage in the Schlemm's canal. Tip: keep the low temperature cautery a little away from the tip to get a just needed flange. If cautery comes in contact with the suture, the flange is too big for the size of the canal. It will result in difficult entry into the canal and may also create a false passage. Tip to avoid false passage. In addition to a perfect flange tip, There is another way to ensure that the suture is in the canal and has not taken any other path. This is to perform an indirect gonioscopy on table using a sterile single mirror gonioprism. The blue color of proline helps in identifying its presence behind the trabecular meshwork, that is in Schlemm's canal. This will also give an idea as to how many clock hours have been traversed and how many clock hours are left. Direction of the tip should be circumferential rather than perpendicular to the goniotomy. What happens if a false passage is created inadvertently? The suture tip can go into the suprachoroidal space and cause a choroidal detachment, which can be managed conservatively with oral and topical steroids and resolve within 15 days. Reduce bleeding from conjunctiva and Schlemm's canal. Make the incision on the clear cornea to avoid any bleed from conjunctival vessels, as this can result in poor visualization. And there are a few tips to avoid reflex bleeding from Schlemm's canal while making the initial tear in trabecular meshwork. Keep the patient's head above the heart level by lifting the head end of the operating table. Fill the anterior chamber with high viscosity OVD like Helon GV or Orogel, partial or semi-GAT. As the proline passes through the Schlemm's canal, resistance is experienced when it reaches 180 degrees as it has to turn the other side. It is an indirect sign that the suture has reached 180 degrees, but sometimes it doesn't proceed beyond this point. Tip in this situation: try twin side GAT, which means threading the suture in clockwise direction rather than the initial anti-clockwise direction. Leave it at the site of resistance. Try to localize the suture using indirect gonioscopy on table. If the suture has reached 270 degrees, then try to make a small nick at that site and retrieve the suture. By implementing these tips into routine practice while performing GAT, one can achieve desirable results. It requires practice and perseverance to master suture GAT, but these tips can ensure a safe gateway to successful GAT.
Thank you.
Thank you, Swati, for such a beautiful video sharing with us. And with that, we come to the end of the session. Any questions from the audience? We can just take one or two questions. None. So that means either we are very clear or everybody is still very confused. So thank you all for being with us. Thank you. And thank you to all our esteemed chairperson, the keynote address speaker, and all the speakers, panelists, everybody with us. I would request all the speakers and everybody to be with us on the dais for a group photograph. The speakers, they are requested to come on the dais.